Thank you so much, King. And you may have noticed that both King and I are wearing a tie. This is a unique opportunity to say that, for me to express that I don't think it's an overstatement to say that my life would have been different if I would not have met the King Holmes. And I would not have been and done what I've done and been where I'm now. But things are often not as they are planned, and so I want to talk a bit about that. But so thank you, King, for the bottom of my heart, and I'm looking forward to many years of maybe going to Walla Walla or other places. But this was, it's quite, for me, emotional to be the inaugural professor. And as they say in Rome, all roads lead to Rome. We can say all roads lead to, to Seattle. I had to go to Africa to get to Seattle, and not so obvious. And as King mentioned, in 1976, I was involved with the first known outbreak of Ebola, and worked there with people from, with CDC. Here is Joel Bremen from CDC, who initiated me in outbreak investigation, because it's not because I was on that team that I had any experience. I had never been to Africa in my whole life, and had never investigated an epidemic in my whole life. And yet I was part of the team, and that's where I always say you need to jump into opportunities, and when others have second thoughts, can go for it. But so after a short period back in Belgium, I went to Atlanta to CDC. But what I really wanted to do was to work on sexually transmitted infections, and particularly as they affect women. Because during my work in Zaire, I had come across so many patients with both acute infections, but also in women with infertility, pelvic inflammatory disease, and I could hardly find anything serious in the literature, except there was one name that came up regularly, and that was a certain K.K. Holmes. And from a place, Seattle, I had never heard of until then. I'm from Belgium, so yes, I'm from Belgium, so what can you expect? And and also at CDC, I thought it was too bureaucratic, not knowing that I would become a UN bureaucrat later on, but this was the fact. So I drove from Georgia to here, and my first night in Seattle was I camped on Mercer Island, and fortunately security was not that enforced in these days. And I was interviewed by King, and since I had my own money, I didn't realize how important that is. Now I know. I had a fellowship. So King said, "You're welcome, and what do you want to work on?" And I had in my pocket, remember, 2 lyophilized vials of penicillinase producing Neisseria gonorrhea from Côte d'Ivoire, from Abidjan, that we had isolated. This was a time when, most strains of Neisseria gonorrhea were absolutely sensitive to penicillin, and you could treat gonorrhea with just a single shot of penicillin. And also other vials of a bacteria that then was called, or would become a Gardnerella vaginalis. And he said, yeah, go for it. And what I was disturbed by was that here was Professor Holmes asking me what I wanted to do. Coming from Europe, it's the professor who tells you what to do. So it was already, and I won't go into the story that at the same time we were organizing the antenna for your television in your new house. That was, you remember these days when you had someone on the roof, someone with a TV, and someone outside. I was the guy outside. King was inside, and then some man I never met was on the roof. So that was my first day at work at UW. So anyway, this was an encounter that really marked me for the rest of my life. And this is in Walla Walla. You see the difference, but I think this was after a party at your home that many years ago. So I think we still look okay. Now, I learned a lot of things from King, but in Walla Walla, King introduced us always as the ultimate experts in Tempranillo. Tempranillo is the grape that is very important in the wines in Spain, for the Rioja and the Ribera del Duero. And this is from one tasting that we had in a blind tasting in Crissier near Lausanne, where King and I had given grand rounds at the University of Lausanne, and our honorarium was was this wine tasting of just incredible wines. We were wrong by several thousands of kilometers of the blind tasting, but so it brought not only STDs but also wine brought us together. Now, a bit more serious. The context that we were working on in '78 was completely different. I'm not even talking about Seattle and all the buildings that are here now, and Microsoft and the Gates Foundation and Amazon, etc., etc. But in terms of STDs, one, it was a field that was completely neglected. I tried to find out how many STDs were considered STDs in '78, but it was something around 20. The etiology of many syndromes was unknown. We did lots of studies on non-gonococcal urethritis, and non-specific this, aspecific that, PID, and so on. It was not so clear. There were some, as I said, the antibiotic resistance started emerging. Many people, including in infectious diseases, did not believe that it would be possible to treat viral infections. Because the paradigm was that, oh yes, you can kill the virus, but you'll kill the cell at the same time in the patient. And acyclovir was basically the first commonly used and effective, antiviral therapy, but that was it. And that happened around these days. No vaccines for STDs. Hardly any funding and research, STD research was all biomedical, so very poor funding. Many places, including in several states, homosexuality was illegal, and above all, there was no HIV. So today we're in a completely different context. We now have, we could add another infection to the spectrum of sexually transmitted infections, Zika virus. We have made major progress in etiology, but a new wave of antimicrobial resistance. We have antiviral therapy for a number of infections that are sexually transmitted. We've got a vaccine against HPV. There's a global community of researchers. Multiple disciplines are involved, major increase of funding driven by HIV, although that's stagnating, and gay rights are there in many places. So completely different context. Now, what I worked on here was, on the one hand, I worked on my gonococcal plasmids and so on. In these days, I was with Stanley Falco. It took several months to sequence a tiny plasmid, which now, you can just send to some group, and that the next day or the day itself, you can have the results. But then worked a lot with Pat Totten, who's here. Great to see you, Pat. And on working on Gardnerella vaginalis and the etiology of non-bacterial or of non-specific vaginitis or now bacterial vaginosis, which was, frankly, retrospectively, a complete waste of time. Because this was the area before we knew that the microbiome exists. And we were still looking at the classic paradigm that one pathogen causes a disease, or a disease is caused by one pathogen. I mean, that's part of Koch's postulates. We know today that it's a bit more complicated and that we have all these interactions that are... But anyway, that's what we worked on. But King also brought me in contact with Alan Ronald here on the right side. Alan is not that wide. It's just pictures for those who haven't met him. Who is from Winnipeg, in Manitoba and Winnipeg, and where they had an epidemic of Chancroid in First Nation people, as it's called now. And Chancroid was supposed to be a tropical STD. And I was probably 1 out of 3 people in the whole world who had ever isolated Haemophilus ducreyi. So I was one of the world's specialists, even if I didn't have much experience. So I flew to Winnipeg. It was the 1st of May, 1979. It was snowing. And, and we talked about Chancroid, what to do, etc. And that was also the beginning of our alliance. And we said, we're going to work together there where there is, a lot of these diseases. And that was the beginning of the Nairobi STD Project with Herbert Nzanzi, who was professor of microbiology at the University of Nairobi. And we had many workshops and so on, usually on the, this is Lake Naivasha in the background. And half of the University of Manitoba would migrate to Nairobi in the winter months, because when it's minus something there. But that became a very productive collaboration. And I became really interested there also in the impact of reproductive tract infections on pregnancy outcome, on the neonatal period, and so on. And this was a book that came out of that Adrian Germain with King and with Judy years later. That was kind of the first time that all the information was put together, and also dealing with the broader and ever-expanding rate of infectious, in sexually transmitted infections. Now, and this is the last slide I show on with wine, but then AIDS came, 1981, and in 1980, and we had been seeing patients in Belgium, where I was working then in a hospital for tropical diseases, and we saw men and women coming from Central Africa with this new syndrome that didn't have the name AIDS yet. And it fitted more or less the clinical description, but we had 1/3 of women, so that was the first thing. And as I mentioned 2 weeks ago, I could never understand why a virus would care about the sexual orientation of its host, its human host. That doesn't make sense. That's a creation of the human mind. And one of the things that Stan Falco had taught me is that as a master of the study of pathogenesis, of bacterial pathogenesis, how do bacteria cause disease and penetrate cells? He said, you have to put yourself always in the skin, in the head of the microbe. So that's what I always try to do. Not easy, but particularly for a virus. And so it didn't make sense to me that this was declared a gay-related immune deficiency, this awful name, GRID. And secondly, I also thought if we see 100 patients in Belgium, there must be thousands in their country of origin. The problem was that the dogma was this is a gay disease, not much interest in, AIDS in developing countries, and hard to find money. But in '83, there was the Infectious Disease Conference in Vienna in September. And we had a dinner, King and Tom Quinn. And Tom Quinn introduced me to Rich Krause, who was then, was his last year as director of the National Institute for Allergy and Infectious Diseases. Since then, it's been Tony Fauci. And basically, on the basis of a 2-page proposal, he told me, okay, here's $100,000 and you can go to Zaire, and if it works out and you find something, then we can talk. That's how it went in these days. Today would be, he would probably go to jail for that. But that was really the startup money, and that came out of this. These are all very good Austrian wines, and then a quite famous French wine came. And so Tom Quinn and I joined colleagues from also CDC, Joe McCormick, and then Bela Kapita from Kinshasa, went to Kinshasa and did a study in Mama Yemo Hospital, which is the largest, probably the largest public hospital or hospital in Africa, and where the wards of internal medicine were full of patients, young adults with AIDS. And we had, it was difficult to publish these findings. Papers were rejected. The Lancet, I remember, it was a handwritten note came back in these days with a letter that this was only of local importance, but in the end it was published, and it really was not discovering that there is a heterosexual epidemic, but it's just as Columbus did not discover America, but revealed that it exists for us, and that changed completely how we looked at AIDS. And for the next 10 years, I would work with Jonathan Mann and others in clarifying the basic epidemiology, virology, the genetic diversity, isolated SIV, CPZ, and so on, the ancestor of HIV, while working in Kinshasa. But then I got some, really, as I call it, the midlife crisis, and I said, this disaster is continuing every year. More people, millions of people are infected, so I wanted to change the world. And again, some of you may have heard that, but in 92, I took some sabbatical leave and went to WHO, which is probably the last place on earth if you want to change the world. Because I wanted to see how policy is made, how you can influence large, and have an impact on the lives of lots of people, and I actually liked it. And then the rest is a bit of history, because to my surprise, I was selected as a director for UNAIDS, an institution that didn't exist. I was employee number 1, literally. And so, to make a long story short, because what I really want to talk about is the future of HIV. And you see here the curve of funding for HIV in low and middle income countries from 86, where it was really very, very low, but it's less than $1 million per year, and then it went up slowly until a turning point was really around the millennium, 2001. Here we reached about 1 billion. And lots of events happened around that time. It was really when HIV became a major political issue, and the creation of the Global Fund, PEPFAR, and there's now about $15–16 million was spent per year. And the price of antiretrovirals came down, and so on and so on. And the net result is a decline in new infections, which started already at the end of the 90s, 98, 99, and of mortality, which started declining around 2005. This is clearly the impact of widespread availability of antiretrovirals also in Africa and Asia. Whereas the decline of new infections is probably partly natural history, partly also the result of prevention programs. So this is where we are, about 1.2 million new infections, deaths last year, and about 2 million new infections per year. And already in 2011, The Economist is always very forward-looking, had this title, The End of AIDS. And whereas it's true, they say how 5 million lives have been saved, and it's true that when you look at it, the 16 million people who are now on antiretroviral therapy in the world, basically all of them would be dead by now if they wouldn't have had access to that treatment. But can we talk about the end of AIDS? People, first of all, forget the question mark. And at the moment, the main message that's coming out, both of PEPFAR and of UNAIDS, is that the end of AIDS is in sight. We will end it by 2030. So what I really want to talk about the rest of the day is, of this talk, is really to reflect on these messages. And is this possible? What are the issues we have to deal with? Is this fantasy land, or is this something that is achievable? And why is there this kind of deep conviction in many people, particularly in the medical community, that the end is in sight. And it's based on one of those classic sound bites that you hear in public health all the time. We've got the tools, all we've got to do is to implement them, and if only these stupid people would respect, take their pills and so on, and change their behavior, it would be okay. So the tools are there, that's true, and a major breakthrough was something that is frankly a classic notion in infectious diseases. When you treat someone and you suppress the pathogen, a virus or a bacteria, then people will be less infectious, and you have an impact on the transmission. And so through both treatment as prevention, PrEP, and coming from various parts, including here from UW. So that's the scientific basis of this. Now, where are we? In the meantime, the treatment guidelines have also changed. Today, the treatment guidelines is such that the earlier you treat, the better, not waiting for a decline of the immune system as measured by CD4 lymphocytes and so on. So if we assume that there are about 37 million people living with HIV, and so in other words, who would, according to these guidelines, need this treatment, about 15 to 16 million are on treatment. So in other words, about 22 million are now lacking treatment and are in need of treatment. And then this UNAIDS and also now PEPFAR have launched a campaign of 90-90-90. In other words, that they said that if we can first diagnose 90% of people who are, living with HIV, that they know that they're infected, living with HIV, and of those 90% put on treatment, and of those who put on treatment, 90% should have viral suppression. I'm not a great mathematician, but I know that 90% times 90% times 90% is about 70%. And that's the end objective, which means that there are 30% of people living with HIV who are not, virally suppressed. And what's really important is who are these 30%? It's very likely that that will include people who have been infected very recently, because detecting them is not so easy, and we know also that they're highly infectious. This is one of the times in the natural history of HIV infection that you have enormous viral loads, so highly infectious. And then also people who are, for whatever reason, are marginalized, have no access to health systems, to healthcare and testing and so on. But this slide, which comes from UNAIDS, gives you an idea of the major challenge that we have to apply this strategy. And let's have a look at the various elements of the cascade. One very important element is adherence, retention, treatment, and it's fairly sobering. This is from a meta-analysis done by WHO and in 41 countries, and you see that after 5 years, that overall, that the proportion of patients that were retained in care was about 40%, 35% after 5 years. Some countries did very well, and others not at all, and there are many reasons for that. And here you can see by gender, clinical stage, and CD4 count, so on. And that's not only in developing countries, but it depends. Secondly, how are we doing in terms of viral suppression? So here you see for 8 high-income countries, and the only the percentage of undetectable HIV RNA, in other words, viral suppression, and it's the highest are in countries like France, the Netherlands, UK, and then also Denmark, where it's around 50%. And it has improved in the US, but these were figures from CDC, and it's around 25 to 35%. Again, and even here in BC, British Columbia, which is one of the main places where they say that all you need to do is treatment, is prevention, the viral suppression is 35%. So that's still a long way from where we have to go. And then we've got some practical problems. We're getting here into implementation, into health systems and social systems. And one of the big issues that that are coming up in some countries, not in all, is stockouts of antiretrovirals. On the left side, this is from a campaign in South Africa where the Treatment Action Campaign is monitoring stockouts and availability of drugs. And it is sobering. And here, this is a map that comes from the Kenyan Ministry of Health themselves, where they see this illustrates, and they're probably one of the best programs in the world in Kenya, I would say, in terms of HIV. They're monitoring, at least, what kind of stock is still left. And in South Africa, the stockouts have really led to major interruptions of treatment, resulting in sharing of drugs, in taking 1 or 2 instead of 3. And this is a recipe for not only for clinical failure, but also for the buildup of antiretroviral resistance. And then there's another issue when it comes to treatment that is, I think, under the radar screen, but I'm myself more and more worried about. The overwhelming majority of antiretrovirals today in lower income countries, definitely, and certainly in Africa, are produced basically in India by generic manufacturers. There are about 10 generic manufacturers left, and with 2 providing more than 60% of needs in sub-Saharan Africa. This is a result of a ferocious competition in terms of prices that have been pushed down, the policy of the Global Fund also recognizing only 2 suppliers, and all, I would say, well-intentioned, and it resulted in lower prices. But this makes it very, very vulnerable. And every year there are producers of generic antiretrovirals that are stopping to produce them. They, because the profit margin is now at about 10 to 15%. So they're switching to other drugs. Huge API needs, so the basic pharmaceutical ingredients, they're nearly all made in China. And just for antiretrovirals, there will be, by 2020, a need for 12,000 tons. And if you know that many large companies only need 1,000 to 2,000 tons a year. Very big barriers to high barriers to local production, because that's been promoted, and the needs for second-line therapy are growing. And final problem in terms of treatment is that I think we are in collective denial about the potential for antiretroviral resistance, although the data are not clear. And at the moment, there are some studies going on conducted by CDC on representative samples to have a look at how big is antiretroviral resistance. And this is from one study that came out in the Lancet, I think last year, and in January 2015. But that was looking at people who failed treatment. And the level of resistance to tenofovir, which is now the core of first-line therapy, was quite enormous. Not unexpectedly, but it points to the fact that we really need to monitor that. And if you believe in evolution, with a virus that mutates all the time, and with stockouts of therapy and so on, this must become a problem in the future. So treatment, a number of challenges, all of them can be overcome, but we we're not dealing with them basically. Now, particularly when it comes to prevention, new infections, 2 million new infections a year, that's not a small number of people. And that's true here in Seattle, it's true in London, it's true in Cape Town, it's true in Kenya and so on. But this is where we have some really major failures, whereas progress in terms of treatment access has been spectacular, I would say, probably unprecedented in international development for a chronic treatment, but that's not so true in terms of preventing new infections. And I think there are what I would call 4 major failures. The last one, when still no HIV vaccine, it's a failure, but that's of a very different nature than the rest, because that's inherent to the nature of the virus, and we made some good progress there. But I think the first failure is one of strategy and implementation. We've shifted the whole strategy from one that was, I think, more balanced between treatment and prevention, originally only prevention, because the resistance to introducing therapy was also ferocious. And now we've gone overboard to the other side. It's all treatment, and when you look at budgets for HIV prevention, they're minimal. They're minimal, and the efforts are not so great. And I think that our biggest failure in the world is the very high HIV incidence in young women, in girls and young women in southern and some of Eastern Africa. That is, for me, the biggest collective failure of all of us, and I'll come back to that. We have also persistent infections and increasing incidence in some places in gay men, with a resurgence of classic STDs, bacterial STDs. In the US over the last, and I don't remember, is it last 15 years, I think there's 40,000 new infections every year. There's not been a decline. Population has grown a bit, but Then we have a failure of policy and politics. And that is, I think, the main driver of the high incidence in injecting drug use in some countries that are resistant to introduce harm reduction, methadone, maintenance therapy, and so on, substitution therapy. And then finally, we have, when it comes to STDs and the failures, I think, and there's a failure of public trust in politics, and that's with a very low uptake of HPV vaccine in some countries. Now let's look at what the situation is and how far we are from the end of AIDS. Again, coming back to to Southern Africa, this is not an incidence but a prevalence graph, and where you see in dark red the men and in pink women the HIV prevalence, and you see how girls and young women become infected at the phenomenal rates. And that's quite well documented in a place like KwaZulu-Natal. This is from a study by Karesha Abdul Karim. And you see in a particular community in KwaZulu-Natal where they're working, the overall incidence of HIV in these girls was, we can see on the left side, it is gone, but it was 9%. 9%. And the Africa Center in, here, it's just 9.1%. Can you imagine what that is? And we failed. We haven't. And there are now more and more studies that show that this is a very complex issue, that we are dealing with an accumulation of micro-epidemics, mini-epidemics. This is again from KwaZulu-Natal, but by the Africa Center, the Wellcome Trust Africa Center, Dean Pillay and his group, and they could map. It's a geospatial mapping of quite a refined way, where the hotspots are for HIV infection. And I think that's the kind of information that will allow us to go to more refined prevention. Again, it's not just a individual behavior, but also it has to do with what we call structural drivers. This is from work by Charlotte Watson, our group at our school, and dealing with gender inequality and gender-based violence, poverty, and livelihood options, stigma, discrimination, and alcohol. And we have to incorporate that in these programs. Now, I mentioned gay men, and we saw in both in the US and other high-income countries for many years a decline in new infections, in chlamydial infection and gonorrhea and so on, and I'll only show some data from the UK. Here we see new diagnosis of these 5 STDs in men who have sex with men, which is a term I don't really like, but anyway. In the UK, and you see how gonorrhea has really gone through the roof. Same thing is happening in many cities in Europe, also in here in the US. Chlamydial infections are going up, and syphilis also. We have now real epidemics of syphilis in lots of places. Will this be get worse with PrEP or not? We don't know. And here's some detailed analysis from the UK, Phillips and et al. Andrew Phillips, and where you can see, it's a complicated slide, but on the one hand, there is a very good suppression of HIV viral load on the upper right side here. This is until 2010. And the number of people on antiretroviral therapy, the number diagnosed per year is going up, but the incidence is going up. Condom condom use is going down, and so we are faced with quite a complex situation. In London today, there are 5 new infections in gay men every single day, and that despite an environment that is very supportive for sexual diversity, where the National Health Service offers free health care to everybody, high rates of testing, etc., etc. So we do have a problem, and it's because it's about sex. Now, when you look also at all the talk about stigma, discrimination, and so on, and there are not that many data. And it's hard to do a randomized trial on it to prove that that really has an impact. But this is just an ecological analysis of a criminalization of same-sex activity and HIV prevalence in men who have sex with men in several countries. And it is so that in those countries where there is criminalization, that the prevalence is much, much higher than in those where it's not. That's not a causal relationship necessarily, but it is suggestive, and it is confirmed by many other analyses. Next point is that about money and funding. How are we doing? Funding has been stable and flat, but also slowly declining. That's true for PEPFAR, that's true for the Global Fund. The Global Fund is facing now a replenishment this year, and that's extremely important, just as the reauthorization and the funding for PEPFAR, because that's the main source for the Global Fund also. And what we're hearing a lot now is that shared responsibility, developing countries have to pay for their treatment. And that is possible for middle-income countries, definitely. And particularly those where there are so-called concentrated epidemics, where for example, in gay men and injecting drug users, but for political reasons, they don't want to do it. And so most of the funding comes from international sources. But many of the most affected countries in generalized epidemics, or hyperepidemics as we call them, and this is here, the curves, would have to spend a major amount, percentage of their GDP, but particularly of their government health expenditure. For example, here, if you would apply the 1990 and the major efforts, between 50 and 67% of total government health expenditure would have to go to HIV treatment and prevention, which of course is not going to happen. And as a result, many countries are totally dependent from foreign aid for their antiretroviral therapy, which is in any case unhealthy. You can question whether they are sovereign states when hundreds of thousands of their citizens' lives depend on, on foreign aid. Now, and then in addition, international funding. This is from the last report from the Institute for Health Metrics and Evaluation on, and you can see until 2015. This is AIDS funding, international AIDS funding, which is being flat, but the needs are going up. So that, before I come to something more positive, is we not only need money, financial resources, but also human resources. And this is the reality. On the left side, you see one of those maps, HIV prevalence in the world, and then physicians as an indicator for healthcare workers on the right side. So we clearly have a disconnect there. So let's now come to the end of this presentation, and that's for the Lancet Commission on AIDS that I chaired. We did some simulations and some projections and scenarios, and even under the most optimistic scenario, which is here, just called Global Agenda, we will, and if everything goes well and we can apply and have the coverage that are advocated, we will still end up with hundreds of thousands of new infections by 2030. Vaccine is not there yet, but there I think that we have to, to rely on recent progress on science, which may or may not lead to a vaccine, but it's absolutely essential to continue that work. Otherwise, we will not be able to, end this epidemic. And having a vaccine is not a guarantee that's being used. As I mentioned, I think one of the big failures today is the lack of coverage of and acceptance of an HPV vaccine, which in Japan is now below 1%. It's become kind of infectious in Denmark. In terms of in the US, it's very variable, including here in this part of the world. So where are we then now? Let's look at the future. Being from Belgium, you may know Magritte, one of our main surrealistic painters. And I'm an optimist, and I don't want to leave you with the impression that it's all negative. We've come a long way. But it's time to recognize that we're entering a new phase and that we just can't do more of the same, that we have to build on our successes, but that the road ahead is going to be very, very bumpy, and that we should not promise what cannot be delivered. And the first thing we need to do is to take a long-term view. This was a consortium that was led by Heidi Larsson, and where we, several years ago, and we were thinking about what is the long-term impact, what are the long-term projections, what do we need to do now for the best possible outcome. So this long-term view is really important. Very difficult in an environment where budgets are voted on an annual basis. And that's where we then came up with this reflection on AIDS. And here is what I think we should do. It's a bit too much. I wish I could say these are the three things we have to do. But what I would call for is a renewed AIDS response. First, putting back what we know that works, combination prevention, from male circumcision, condom use, and all that. It's very interesting to see when you go to an AIDS conference today, it's all about ARVs, the word condom would not even appear on in most people's minds or slides. Combination prevention should really be taken seriously. Of course, sustain ART. But then I think a concept that I think is going to be as important as precision medicine, that is precision population health or precision public health. What do I mean by that? You can go to the genomics of populations, but I think here it's more about risk profiles, dealing with these various mini and micro epidemics, and tailored interventions along these lines. Kenya is a country that in its national plan has gone a long way to that, and taking sub-county level as the unit and then adapt the strategies, the interventions to that. But that's for me a major element of the new response to AIDS. This is also about health systems weaknesses and primary care and working with other programs. And when I translate that, since we're here in a university, that should be guided by implementation science. That science is going to be as important as finding a new vaccine. And then finally, more on the how and on the supportive environment, we should continue to counter all the issues that are, obstacles to effective programs and violations of human rights, stigma, discrimination. I think we need renewed leadership, probably not only in governmental areas, but also activism. Where are the activists? I know them all. There's a problem. I'm 67. I shouldn't know them all. Rebranding AIDS probably, because now how are we going to explain that AIDS is not going to be finished in 2030, and yet without demobilizing everybody, how to do that? That's a big challenge. The funding is there, and then R&D on vaccine, So to conclude, I mean, it made me, have been used a lot, but we've climbed a great hill and many great hills, and I think we should be proud of that collectively. It's the work of literally millions of people on the ground, but there are many more hills to climb, and if we just only look back and be very satisfied with what we've done, I think we risk that all the these achievements of the past will disappear. So thanks a lot for listening to me. Yeah, I mean, of course, we could not say, as some of our colleagues say, we first need to fix all the health systems and so on before we can achieve better health and bring AIDS under control. But the reality is also when you look at some of the issues that I mentioned, particularly in terms of treatment adherence and access to counseling and so on. I mean, that has to be done by a system. And I think that could be another talk, and there I would not be inhibited by any lack of knowledge in this field. But I think there we need some other thinking. And what do I mean by that? We are trying, I'm thinking of particularly low and middle income countries. We're basically, whether we're coming from the UK or from the US, we're trying to impose our healthcare systems on these countries, and I think the evidence is pretty strong that our systems are not ideal. Okay? And maybe some of them are even on a train wreck scenario, whether it's the National Health Service in the United Kingdom or the American system or something, or the hybrids in Europe and so on. And so we need to, I think, support countries to come up with something that is fit for purpose. And when we are confronted with a lack of human resources, so the classic human resources, healthcare professionals in countries, it's going to take decades before we can train enough doctors and nurses and all that. So we need other ways of providing delivering the services, the prevention services, and so on. And that's where I think innovation and technology could help. It's not going to fix all the problems, but I think we need to think that one through. I mean, we talk all about task shifting, for example. Would be great, but there's enormous resistance against that, and it's not so easy because you want to maintain a certain level of quality and so on. So I think that with HIV we have an opportunity also to perhaps experiment and to try out new ways of working, and particularly when it comes to chronic care, because ironically in many countries it's the first time that chronic care has been organized in a systematic way, which doesn't make sense because hypertension has been there before there was AIDS and so on. But anyway, that's the reality. So I think some good investments, and with also, I would say, experimental designs, and that's what the implementation science should be about. And try it out, because maybe we know exactly how it should be, but be organized. I don't honestly know for sure. The challenge is that the solutions may be very context specific. You know, what works in Malawi may not work in Thailand and or in even a neighboring country. And we have to accept that. But that's hard to accept for research funders or for other funders, because we all want a universal solution. You know. Yes. So
Peter, to follow up on that, given that challenge, how should institutions like the London School or the University of Washington be changing their teaching so that we produce the capacity we need in the generation of health professionals tomorrow?
Thank you for the small question, but no, but we have lots of discussions about that. I mean, and I hesitate in my answer because I think for certain areas we need specialists and people who know everything, about maybe a small area, and we need that. It is when it comes to, particularly to health systems and health service organization. And there probably the best teaching is to equip the students with methodologies so that they can come up with the solutions in their environment. And it's just like, that's what I like about business schools. Many years ago, I went for a course at Harvard Business School, and they came up with this case study method, and I revolted against it. I said, this is all nonsense, because in our training, you are trying to find out whether something works or doesn't work, whether it's right or wrong. That's the biomedical type of paradigm. In a business school, then it's okay, a case study, you study how it went, and some went bankrupt and others not, and you try to understand and so on. But I learned a lot from that, and it told me also that for doing business, there is no universal paradigm. Okay, there are fashions and consultants and so on, but I think that's maybe what we have to do. So in other words, use some of that kind of approach in our teaching, but to be honest, it's not very popular in our own school when I say that. Yeah, but it'll change. There was someone, yes, please.
Welcome back to Stockouts for the question. I wanted to ask about the issue related to this sort of end of AIDS, and your thoughts on how, because that was used, I think, to help garner funding, I talked about it as a very difficult problem, but what is your suggestion for how to approach that? Because we're not going to be there.
No,
and yet we want to maintain funding. So how do you see that?
Yeah, I think that was a strategic mistake, and also it works, for a year or two or three, and it can work if you can eliminate or eradicate. I mean, like polio, we can promise the end of, the elimination. So there is an end point. Here for HIV, it's not the case. And so in Europe, I can tell you this has already been counterproductive. The UK, which is, by law, is spending 0.7% of its GDP on international development, and so it goes up every year, well, HIV is no longer on the agenda. And then when I talk about it, I say, yeah, but it's, you know, it's on, it's the end of AIDS. People don't think about as a, when you know it's refined as a public health program by 2030, and then it will be further refined. But that's not the message that these people hear. So I don't know. I think this requires some serious thinking with also professionals and politicians, but you can't use that for forever. So I feel quite bad that I have to come with a negative message. I'm kind of, I think, a positive person, and yet I think if we're not starting to, to face reality, and how do you say that in New York? Wake up and smell the coffee. It's no, but then it will get worse and worse and worse. But how to, and in a year of replenishment of the global fund, for example, I don't want to undermine optimism. And what I believe we can do is a better job, bring down further number of new infections and so on. But I think also it's also like an AIDS-free generation and all that. I mean, it's when I was head of UNAIDS, I can tell you that there was never ever published like that, because I always feel that you have to be ambitious, but you should not promise what you cannot deliver, or where you think you can't deliver. I mean, maybe I'm too pessimistic, and maybe I hope I'm wrong. We had, yeah, here.
Small question, but you mentioned that you didn't like share your was on the why.
I find it such a clinical description. I don't have an alternative, but yeah, but it is. I mean, I've sat in many meetings, believe me, where to say how to define it and so on, and it's clinically correct. But I find it kind of, we don't talk about men who have sex with women or women who have sex with women. Well, so women have sex with men, and then we say heterosexuals, and so. But it's me, so don't pay too much attention. Don't pay too much attention to that. It's not as bad as the end of AIDS. as saying that I'm going to be in deep trouble, I think, with this talk. But yes, then the last one. Sorry.
Peter, we've had the experience of some vaccines already now becoming in short supply or non-supply because of manufacturing issues and the payoff between what you can sell these for. And you talked about some real constraints, I think, in terms of manufacturing of ARTs. Could you say something more about how critical that is? Do you see that will, sort itself out, or is that an area that needs more attention?
Well, I think vaccines and antiretrovirals are a bit different, because for vaccines it's probably better planned and at the moment more predictable. But also we have a yellow fever epidemic, an outbreak in Central Africa, where there is a shortage of yellow fever vaccines. There are only 4 manufacturers, government in Brazil and Russia, and then Institut Pasteur in Dakar, and then Sanofi, and it's still in eggs. I mean, it's this. So anyway, that's a particular problem that we've. I think on antiretrovirals, as much as I worked hard to bring down the price of antiretrovirals, I think we probably should no longer push further to bring that down, because there is simply no incentive. Generic manufacturers, in contrast to what some activists may think, do this because they see a business in it. It's not because of they're an NGO. And so we need to, I think, to sit down and make sure that the supply keeps up with the probable growth, and hoping that if the money continues to flow, that the number of people on antiretroviral therapy will continue to go up, probably at a slower pace, but still. And one can fairly well estimate that. Not yet for second-line therapy, because there are no good data, but that I think we will know quite soon. And then sit down with these manufacturers. Also, if they have a better idea of, in advance of what the market is, that all helps them as well. And that's been used with vaccines, so we need to play on that. I'm not pleading for increasing the price of antiretrovirals, but there is a limit, and if you can make 20 or 30% profit on anti-hypertension drugs rather than antiretrovirals, the decision is rapidly made. So that is a discussion that we need to have. And that's where I think is also a need for leadership, but that's where the big payers, I mean PEPFAR and the Global Fund, and then a few countries, they could get together and then see what to do. And maybe my concern is not justified, but we've seen also in the vaccine field sometimes, and if the number of manufacturers comes down, at some point the price will go up. I mean, that's what anybody would do. No?